You're Princess Leia. Princess Leia.
As long as I can keep my hand on it.
Yeah. Well, we'll see.
We're on live.
Hey, I have something for you. I'm your father. Okay, let's start. Go.
Hi guys, thanks for joining. This is Essence of Medicine. Today we're talking about the psychology of patient care. My name is Amanda Armagast.
My name is Alyssa Hopper.
Dominic Moore.
And I'm Dr. Abbasi, and three of us are providers. What is a provider?
Well, someone that would provide care to others or provide in general, someone with something.
Mhm. What is, Dominic, what have you noticed about relationship that you will have eventually? You have observed that you just finished your PA school. Congratulations.
Thank you.
You will be a provider, meaning providing care to the patient. What is different in relationship of a provider to a patient to any other relationship?
Okay. So patients, they really depend on you. They come to you seeking knowledge that they realize that they're not going to have. They're not going to be able to just look up stuff. Sometimes they'll try, but a lot of the times they're basically putting their health and their life in your hands and saying, I understand that you're a professional, but I also want you on an emotional level to trust me and act in the best interest of
Trust. You've mentioned that trust is about
Mhm.
this. Now, imagine a patient comes to you. You have never seen that patient. They just strip naked in front of you and give their body to you to take care of them. They come to you. They give the best thing they had in their life, the children. They hand it over to you, and they trust you to do the right thing for the patient. The whole premise of patient and the provider, and I consider you provider. I know there's a big outcry, oh, provider, I'm not a provider, I'm a doctor. No, we are all provider. We provide care. Now, would a patient just strip down to go to a shopping mall or go to this and that? Well, in some situation, maybe you go to a massage parlor, yes.
But
But
that's still like almost a patient.
It's a
type.
professional
Yeah.
environment.
No, but-
One would
Trust.
hope.
But
Yeah.
it is, I just want to put the provider-patient relationship to a different level.
Mhm.
Now, but still this relationship between two human,
Mhm.
right? And yeah, we all know human, all of them, if they're provider, if they're patient, they have their quirks and
Mhm.
they have their stress. We are still human. Now, this episode is about my experience that I'm hoping I can convey to you from the last being a provider for the last 30-something years, about what makes that relationship better, more trustworthy, and what makes it worse and less trustworthy, and how you can convey to the patient you are there for them, but then you have to be genuine, you have to be there for them, and what definitely move you from the provider to from the provider they would trust to some area that they become adversary to you.
Mhm.
So I want to actually ask you, Amanda, I'm sure you have had lots of contact, lots of practically interaction with medical professionals.
Yeah, for sure.
Why don't you tell me one of your best and one of your worst experience in that regard? And I want to dissect that, three of us, we want to dissect that. What made the good one a good one? What made the bad one a bad one? Please go.
Okay. So I had a really good experience recently where it was a younger doctor and it was a male. How much detail should I get into?
Well, it is your story. You
Okay.
can get into as much detail.
I just don't
because-
want to make anyone else
No,
feel uncomfortable. Okay, so
HIPAA, by the way, HIPAA is that everything that happened to my patient, I cannot disclose, but patient can disclose whatever they want. Go
So
ahead.
I was facing a lot of stomach issues recently. Ever since I came home from Germany,
Damn Germans.
I have been like really going through it. Eating certain things is like almost traumatizing to me, where my stomach is getting so bloated. So I went to the doctor and he was really patient with me. He was really, why are you laughing?
I've relieved the pressure.
He was being very understanding. And even though we were really close to the same age, he didn't make me feel uncomfortable to talk about like my bowel movements and things like that. Where other times it might be uncomfortable to talk to someone of the opposite sex, similar age, about your bowel movements. He would tell me like, it's okay. You can say it. Like I've heard a lot of crazy things. And he didn't ask me questions to make me feel like maybe I was making up my symptoms or being over dramatic about my stomach issues and things. He ordered an x-ray for me right away. And then he showed me my own x-ray and then walked me through it. He was showing like, do you see these black things? This is like air. And this is all constipation. And then he really walked me through like my own treatment plan.
Mhm.
He let me ask as many questions as I could, and he didn't make me feel rushed at all.
And we will come back to dissect that. Let me know, would you like to share one of your not very good
Yep,
or
I'm
worst
ready
experience?
to share that.
Please go ahead.
My worst medical experience would be when I got my IUD put in and removed. Both were really traumatizing. I don't know if anyone that's watching has had an IUD, but they're so painful, almost to the point that you could like pass out from that pain. I almost did. I was nauseous. I couldn't drive. And she was making me, I'm even getting emotional
Mhm.
like now, like she was making me feel like it's not that bad. You can have like 2 minutes, then can you go? Stuff like that. And I've never gone back to that doctor again because I actually left like crying because it was so painful. Like I was bleeding. It was awful. And she just made me feel like you asked for that. You asked to have an IUD. You knew what the IUD was. I showed you the video of what it looks like. She didn't offer anything like, do you want an ice pack? Like, do you want water?
So, guys, you wanna just sorry for that experience. I mean, that is every time is traumatic when you are giving your existence to somebody else and they don't fulfill their part to take
Yeah,
care of it.
and
That
it's
is
like-
traumatic.
Also, when it's like so personal, like
Sensitive,
Yeah.
you know,
your
and-
reproductive system.
and like,
Yeah.
I want to, when you bring that up, because as a younger female, we know that a lot of nerves, a lot of things in our low
Yeah.
back take care of a lot of things that men, particularly, you know, older men, don't want to talk to me about.
Mhm.
Yeah.
I get it.
And maybe
I-
they don't
I
understand. either.
understand 100%
Mhm.
why. That's why I go into those situations, normalizing it 110%, even if they don't have it. When you ask those questions, make it seem like, oh, okay, well, just so you know that this is a possibility. So if you do experience these things, just know, you know,
Mm.
because to them, you know, whether it's bladder, bowel, erectile dysfunction, you know, those are not fun topics, especially when you're sitting in front of a, you know, 26-year-old female
Yeah,
provider.
yeah.
I get it. I
So-
get it.
So let's dissect your both stories.
Yeah.
And, you know, the first story, the good story. Dominic, what do you think made that a positive experience from just listening to her?
Yeah, I would say it's as simple as that person saw her as a person, not just
Mhm.
another encounter to get
Yeah.
through. They recognize things that might be awkward for her, not just, oh, this happens to all my patients sort of thing.
Yeah.
Just
But let's break it down because for us, you know, treating her like a person is made of some elements. There are some elements to that makes that encounter.
I
treating
say
like-
what I noticed the most about this,
Let's
which she
count
noted
it.
was basically this provider allowed her to drive the boat, is how I describe it.
That's
Put
true.
her in charge of kind of, you know, how do you want to go about this?
Mhm.
How would you like to proceed with the questionings? Like he seemed to allow her to be in full control, of the
Well said.
situation.
Let's put the patient in charge, on the driver's seat.
Mhm.
You are there to help the patient, not to berate them. Now,
Mhm.
meaning that they make always understand you are there to give them advice and help. It's about it's their body, it's their choice, it's about their decision. Make sure that, before you can do that, you have to inform them.
Mhm.
So you cannot put somebody in the driver's seat with a blindfold, right?
Right.
Not giving information and then putting them in a blindfold is equal of putting him in the driver's seat with a blindfold. So, and that is one of the things we do here in the Inspired Spine. We go to the room and I look at the pictures with the patient at the same time. They see my first expression about what I see. I haven't made my mind looking at the films already when I go there to have a plan. I want the patient to see the films with me, make them truly understand what the problem is. Like you expressed that very well. He showed you where is the air, where is the constipation. They don't need to be doctor to understand that. And I can tell you, once you use the right words, you can, and you don't have to use lots of jargons to make the patient understand what the problem is. But once you explain that, they do understand. Everybody who tells me, oh, patient wouldn't understand, that's so 1900 mentality of the surgeon. That does not apply now. So, well said, put the patient in charge, but before that, communicate with the patient, make them understand that, and then you have to use a language that is, I'm not going to use the word dumb it down. No, you are not, you don't dumb it down, but like there are lots of analogies that you can use. Like one of the analogies we use for a disc is like a tire of a car. Yeah, well, the people understand that because everybody had a flat tire.
Correct.
Then you understand that what
Totally
it means,
situation.
that the way the rubber bulges out is the way the disc bulges out, and if there's a nerve next to it. So these analogies really help. So our podcast is about the psychology of patient care. And we are going to come up with some practical steps to achieve that. And again, I want to be absolutely sure that people do not understand when we talk about psychology of patient care. It's not about that we are manipulating a little child here. It's about using the method to establish trust. Coming back to your situation.
Communication too.
So use analogies. Develop a series of analogies that helps you to explain the situation to the patient in a more straightforward case. Do not try to dumb it down, and don't be afraid to say, I don't know. You will see if you are in a place that, they ask me sometimes obscure question that I really don't know. And I say, I don't know, I can guess here, or if it's something outside of my expertise, I say, I apologize. I understand what you're trying to tell me, but like problem with this area and that area is outside of my expertise, but I can find an expert for you in this area. Do you wish me to give them again in the driver's seat? I know you have some problem in the shoulder and so on. My expertise is not really in the shoulder, but it could be part of the problem. But I like to, maybe if you like me, I can send you to expert to evaluate that.
And that's what you just said too is also really important for patients, even if you don't know if it is or isn't, saying it could be. So you're still making them feel like they're not crazy.
I'm not shutting them out.
Yeah.
Yeah.
Okay. Now, and you word that word. One of the first thing I do to establish trust with the patient, when I come and look at the picture, if there's a pathology there, I say, wow, I see why you're having the pain. Give them affirmation. Give them affirmation that you understand them. Okay, these are practical things, not a theoretical, philosophical thing. You go in, look at the films, establish eye contact with the patient, not going in, not even look at the patient, going to the computer, start taking care of the technology rather than the patient. We take care of a patient. So again, practical thing. You open the door, you call them by their name, and you ask them, did I pronounce your name right? Okay, again, like a checklist.
Name? You get a lot of Michaels,
I prefer, everybody's different. I prefer to address them with the Mr. and Mrs. And this is my preference, and for different reasons. But it is a personal preference. Correct. That you can address them with the first name and so on. I'm just from a generation that to establish the trust between me and the patient is I will have my hands in patient's brain and spine.
Mhm.
Okay, so that requires to have some distance. Can you stop that thing? Thank you. And but this is
It's kind of
personal
like, when
preference.
they say like, not to bring a family references, but your mom can't be your best friend.
Yeah,
Like, you
or-
can be friends,
yeah.
but you can't be best friends.
Mhm.
No,
Same
the-
way as the
yeah.
surgeon. You want to be
you
friends
might
with your
return
surgeon,
it. You might
but you
return-
gotta,
Thank you.
but you don't want to be
Yeah.
like, oh, best
No,
friend.
but
Right, yeah,
But
right.
That's,
In your
at some point, you
professional.
have to have that professional relationship.
you go
Right.
in, you make eye contact, you address their name, you make sure you pronounce their name right.
Mhm.
And then one of the first things you do is, if you notice something on the films, you give them a gesture that you understand they're
Mhm.
there for a real reason.
Mhm.
That is the first step. No, a firm handshake is usually a good way, not only to establish trust, but as well, you see if they have weakness. Sometimes I go in a room in 30 seconds, a scribe says, but you didn't do this, you didn't do that. You didn't see the 500 thing I did at once in that. That
Mhm.
is experience,
Mhm.
and you will learn with time that everything you do is establishing trust, communicating, and examining the patient at the same time. And it's amazing how much you can achieve just observing the patient doing certain things. Now, so you go there, you do all of that, you put them right away in charge. So one of the first questions I ask my patient is, I know I have read what Alyssa said the last visit and so on. And I say that I'm not uninformed. I'm not
Mhm.
just showing up. I'm not the random dude.
Patients will call you out on it.
Yeah.
Trust me, I do my research, but they've tried to trick me. I asked them a question. I said, oh, I see you had the surgery back in 2019. Tell me how it went. Well, don't you have my records? Haven't you seen that? Didn't you read up on that?
Yeah, yeah.
I go, well, I did. I wanted to hear it from you.
Yeah.
That's
You
That's a
know,
good way.
they
Now,
will
yeah,
try.
so I have learned to even overcome this before even they do that. I say few things about what I know,
Mhm.
then I don't let them even go to that next step to do that unnecessarily. Have your but then I add to that. But I want to hear from you. What
Right
is
away.
bothering you? I want tell me what's bothering you.
Right.
And then they start, giving them their story. A good advice to both of you. Let them talk for a good 2 minutes. They will start 90% of the time, or maybe less, telling lots of information that may not be relevant to their actual visit. Again, psychology of patient care. Let them talk for 1 to 2 minutes. That is the 1 to 2 minutes. Even everything they say is really not their regular care. Once they have taken off and have talked to you for 1 or 2 minutes, then they have gotten that big load off their back.
Mhm.
But then make as well, I need to tell you, if you don't control the situation, you will have 10 angry patients after that patient. So you
Mhm.
have to, as well, not just take care of one patient, you have to take care of all the other patients that are waiting in the waiting room. So you have to narrow it down. So, and again, practical steps. You let them talk for a minute or two max, but then if they don't come to the direction of giving you relevant information, you have to define what those relevant informations are that they're looking at. Like if somebody comes and says, yeah, I'm here because doctor this and this said I have need a 5-level fusion and so on. That's important information, but not at that moment. I say, tell me, what do you feel? What are your symptoms? Why are you here? What's bothering you? Use exactly these words. And then try to find out what their main symptom is before you make a diagnosis.
Right.
Never go in a room with a diagnosis.
Mhm.
Okay. So we go over that hurdle, you get the information and then you have to refocus them again. Now, there is rare that somebody comes in and gives you always the information you really need for making the diagnosis. And make no mistake, this is not a social visit. You do some social visit, you give it some appearance about, in some cases, if I see patient is, this is another practical tip to make a connection, establish trust.
That first impression is very important,
Yeah.
especially for the company as a whole,
Yeah,
from front desk to all
Yeah.
of us.
Oh, yeah, for sure.
yeah. But once a while, I see that somebody need truly an additional notch to make a personal connection. They like we had this pilot lately and so on. And, he's a high-level person. He want to make a personal connection to person who's cutting him open.
Yeah.
He want to know that person is a relatable person. You feel that when the time comes, you feel those, you figure it out. Then pick up one thing from their personal life. This is not manipulating the patient. This is again establishing trust. So regarding that pilot, I asked him to answer me a question about the airplane that I'm interested. Now, you know what? If you do it right, you can learn from them. Every patient knows things you don't know.
Yes.
Okay. So, and that put them, they feel proud of giving you something you didn't know.
And this goes, Dominic's gonna pick up on this real fast, and I don't know how good your memory is all the time, but I'm really big on,
Who are you?
I'm really big on those things too. For an example, I had a patient who I did a post-op call and she tells me, I got engaged. And, I'm like, holy cow,
Yeah.
congratulations, that's
Yeah.
so awesome.
Yeah.
Then I see her in 3 weeks and my first thing I walked through that door, I said, let me see the ring.
Yeah.
And she goes, she knew, like,
You
oh, you
won-
That made
remember.
her day.
I
You've
did
won
not
that patient
forget.
for your life. You've won
Mhm.
that patient for
Well,
life.
but that's the thing. That's not my goal is not to win the patient.
No,
But
but
that's just
Well, that's a
establishing
normal human
trust,
thing.
no.
exactly
that
well, yeah,
establishing trust is winning a patient.
fair.
Okay, so that is
Fair.
in a way we do. That patient will follow your advice. That patient will comply. Is the most clear will be. They don't want to disappoint you.
True.
Now, some patient they come to me and they are sorry they didn't follow the recommendation or the advice and so on.
Mhm.
Let's get to that right now. But if they trust you, they feel bad
They
not
do. They do
doing-
feel bad.
Yeah, but then what do you do? If they come and say, doctor, I'm sorry. I know you told me not to do this and that, but I'm smoking again and so on. What is the reaction? Dominic, you should take this one. What should be, you come here, you tell me, doctor, you told me not to smoke. I'm going to mess everything up. I'm sorry, I couldn't. I start smoking again. What's my reaction? What am I going to say to that patient?
Yeah. That's how it goes. You've already started. When do you want to stop?
No, I say, I'm here for you.
Oh,
This is not about me. This is about you. I'm giving you the advice. Whatever you do, I'm here to take care of you. I will take care of you. But part of me taking care of you is to tell you smoking is falling from a building in slow motion. You will hit the ground one way or another. I haven't done my job if I don't give you that information, but let's move on. What can I do for you today? What can I do for you today? Not how you can live your life to satisfy my need, but what can I do for you? Establishing trust is the most important. Now, let's go take another scenario. You have probably seen lots of patients that are fuming in the waiting room when they come into the room, and you have seen that waiting too long and so on. But if you have observed them, very few of them go out of the room fuming.
Yes.
And now you have waited there 1 hour more than you should have. You come to the room, you're already angry. So practical thing, patient psychology of taking care of the patient. What is the first thing you do and you say?
First thing I say is, hey, thanks so much for waiting for me. I really appreciate you, hanging out.
Or straightforward,
I'm
I
I'm sorry
apologize.
yeah, right. I'm sorry. Like I'm sorry. And thank you so much for waiting for me.
Yeah.
It's a pleasure to meet
Yeah.
you.
And as well, if that doesn't, you look at their face. If that doesn't open up the face, you go one step forward. You explain why you are late. I apologize. I never push the patient out of the room, and some patients just need more time, and that is why I'm late. You understand? You make them understand you are not late because you were on your YouTube channel or you
Taking a nap
and
in the closet.
and my patient, like I was in Kansas. I mean, every place has its own patient population, but I was in Kansas. Some of the patients were 3 hours late. But
Wow.
not a single patient was angry. And now we have Dr. Jahvari here in the corner. In some areas of the world, that is normal, and patient wouldn't even think about being angry. But here in the United States, patient would be, trashing around and be extremely angry for a good reason. But once you explain to them, now in Kansas, nobody was, because they saw, I didn't, as a matter of fact, I didn't have time to get even a cup of coffee. So
That's out of character.
I know, it was hard. It was hard. Okay, but no, that is something you can tell to the patient that, I have been taking care of patient from the early morning, and the only reason I'm late, but you don't have to volunteer that. But most of the time when you do the first step, I apologize for being late. Thank you for waiting. How can I help you? And then if the face doesn't open, then you can go to the next step. 98% of the time, that's enough. Okay.
Now, kind of to go for the time there, a lot of the times I've heard that patients will be less upset if in general they know that maybe it'll be a little bit longer.
That is as well a part of psychology of patient care, that let them expect, have a realistic expectation about when things are going to happen. But that is the psychology of the patient care for the institution, not the psychology of patient care for provider. But there are multifaceted care there. Okay. So
I think I'm sorry, I don't want to pull you off topic, but there's a topic I specifically want to talk about. And that is the psychology of patients' family members that are also in said room.
I would love to, yeah.
we will talk about it. Absolutely.
Okay.
That's very important. But let's go to
Okay,
Amanda's story.
Sorry, I jumped ahead. I want to get there.
No, we
though.
will get there.
Yeah,
We will get there. No, let's go to Amanda's story. Now, he came, he made her feel comfortable, but say that you can use your word. Like when you're talking to somebody else, use your words. You don't have to feel embarrassed.
Yeah, he did say that.
For things that are natural. Okay, we are all made of parts, and those parts, what makes us who we are, and they are, all of them need medical attention eventually for anybody. You don't have to feel embarrassed with me. I'm the doctor. I'm the person, exactly the person who you should disclose it. As a matter of fact, if you don't make them feel comfortable about that, then you don't get the information that's necessary for your patient care. Okay, one of the things is, you will experience that after the surgery, people come and ask me about when they have sex and so on, when they can have sexual intercourse and so on. We don't need to get into the details of that, but first of all, you say, no, this question is a very good question, is a natural question. I'm happy you asked that. And then I go and explain that to them, what the answer to the actual question is. And most of the time, answer to that question is, there are so many ways of having sexual connection to somebody. And there are ways that are less traumatic to the spine than the others. You be a passive partner, but then you give them the information, and you would see they are very appreciative of that. And most of the time, I tell them, if it makes you sweat, then maybe it's too much for your spine around it. So be more passive partner, do it in a way that your partner is doing most of the work, but you make them that is the most natural thing in the world. Okay, because it is. It is the most natural thing in the world. I mean, that is why all of us exist.
You really can't get
right?
more natural than that.
Yes. So, but you have to, you don't jiggle about it. You don't blush about it. You act like it is the most natural thing, and it comes natural to them. Then they open up to you and ask the question and so on. And sometimes, like, you have to as well make an opening, if you feel that they're tiptoeing around that, again, practical tip about, what can I do? What can I not do? And so on and so forth. You give them an opening, what activities are hard for you to do. Okay. And then, then some people, then that takes that as, intimacy, being intimate, and it's hard for me, and so on. So and again, all along, you make them feel comfortable. So he made you feel comfortable.
Yeah.
He explained to you, he made the connection. He understood that your symptoms are serious, and he didn't dumb it down, but as well, he didn't make.
He didn't over-explain anything
Yeah.
either. Yeah.
Now let's go to the bad experience.
Well,
What
actually, some other things that I liked about
Mhm.
him is then after the conversation before we had the x-ray, he kind of talked me through what are the possibilities. Like, we're going to do this x-ray, and then maybe after that, you might need to do this, or you might need to do that. So then after I had the x-ray, he came, he looked at all of the images with me, and
with
also
you,
with me in
not
the room.
coming just explaining to you,
Yeah.
but made you understand that again.
And he showed me the photos of it. He let me take photos of it. And he's even kind of put himself in my shoes. And he said, like, when I have these issues, this is what I do. And I was asking him like about Metamucil, things like that. And he's like, when I take Metamucil, I mix it with my orange
I'm getting
juice.
jealous of him. He's
I know.
such a fantastic
awesome.
doctor. Yeah. So
Yeah.
now one of the things is that is another thing is about you give the patient, you make them understand, you communicate with them, you put them in a driver's seat after they understand that what's going on. You make them understand they're in the driver's seat, that you're giving them option, but you weigh the option for them
Mhm.
by like saying, I would do this for this situation. And so he did. He
He made it feel like everyone has, I mean, everyone does have constipation. I
Yeah.
know that already, but hearing it from the doctor saying like, when I feel constipated,
Mhm.
and then he even said like, I personally take Metamucil every month to clean my system, and that made me feel more comfortable too.
Yeah. So, and then he gave you options and then weighed the option for you, and that make it practically a very good interaction and establish trust and so on. So let's talk about the not good experience.
Yeah.
Now, again, I want to go with you guys. You remember what she said about the bad experience.
Mhm.
Pick up few things that you think is a red flag. Absolutely never do that, and so on. And give me your, by the way, you can imagine if you practiced 30 years, every wrong thing I have done before, and I've learned from that. Okay.
Yeah. Well, she was closer to your age.
So, but let's talk about what was the points that made that a bad experience.
Yeah, it sounds like a lot of the inverse of the good experience. So, for example, the driver's seat, she was not in the driver's seat. In fact, she was even told, like, hey, can you kind of get out of here? More of a passenger.
I had to leave. Yeah.
Mhm.
No, and yes, but it's even more than that. She played her symptoms down. Like, don't act like that. It's you knew what it is. Just toughen it up, or man it up, or woman it up, or whatever. It's not a big deal. One of the thing is that is absolute red flag for few reasons.
My number, well, other than obvious things said, is she just didn't even want to believe her. Sometimes, we all say you got to believe the patient, no matter what you say, you have to believe the patient. Now, we all know at times you can pick out, who's a little less believable, but it doesn't, for the experience, you still show that you believe them. You still give them,
seriously.
You give them the benefit of the doubt. It doesn't sound like there was even like, it takes a lot of effort to not care.
So let me tell you some practical examples. I'm going to do an injection. I haven't even touched the patient. Patient is jumping, and I put a needle, and they start, using bad words and so on and so forth. So I'm giving you a multiple choice, and you tell me which one is right. I don't react to that at all, A. And B is, I said, just, just, it doesn't take long, just hold still and so on. C, I know it's hard. Nobody likes this. You're doing great. Just hang on. I do my best. So obviously the answer is C, right?
Yeah, I'd like to
So-
hear C.
Yeah. So you tell them that they're not crazy even if they're crazy, you have to tell them they're not crazy.
Exactly.
Yeah,
Okay.
the crazy is real for them.
Because let's
Right,
be
it
clear,
is- it
okay?
is real
We
for
are not
them.
going to lie here.
Mhm.
There are some people
Mhm.
are people, some people act crazy.
Mhm.
Okay, so but even if they are, you have to still take it seriously.
Mhm.
You have to acknowledge that the pain for them is real. Okay, and then do whatever you can to mitigate that for them, and always it's for a word of affirmation that you are doing great. This is hard. I know this is hard. And tell them
Mhm.
that what they are going to gain from it, that this will help us to diagnose this and that.
Mhm.
This, and you give them a reward by just telling them that you're doing great. You give them a reason why they should go through this pain, and you take the pain seriously. Okay.
Mhm.
Never play it down. Okay.
Mhm.
Don't play it up either. Okay. You don't have, you have to stay completely in control of your own emotion when you are
Mhm.
dealing with the patient, because this is not about them satisfying your emotional need. This is
Mhm.
about like if they can curse whatever they want, and and there are some levels of that, obviously. Okay, if no, but that's not what we are going to talk about today. How to treat, how to work with abusive patients, because there are abusive patients as well.
Mhm.
Okay, but this episode is not about that. This episode is about establishing and maintaining trust with the patient. So, that was one of the things that she gave you the feeling that you should be dealing with that. It shouldn't be a big deal, and you're overreacting.
Yeah, where she's like, oh, it's just a pinch.
Mhm.
And it's like, no, what is it, like your
Tenaculum. Yeah, your
uterus
literally pinch. What?
or your cervix?
Your cervix.
Yeah.
Yeah. Well,
You take a tenaculum and you pinch the cervix and they lift it up. And if you
yeah.
don't know what a tenaculum is, look it up.
I had mine taken out.
Okay,
That
I'm
was-
a reason I'm not gynecologist. I don't want to know the details.
There's a
Hey,
reason.
The reason I do not want to be a-
Yeah,
okay.
what would have
Can
made
you
me
discuss it
what
offline?
would have made me feel better in that situation is if she said like, yeah, I know this really hurts. Do you want some water, or can I give you like something
What can
like
I do?
Acknowledging it, acknowledging
Yeah.
it that is real.
Mhm.
So what else do you think, that Amanda was mostly really turned off about and really annoyed her in this thing? There are a few things I heard from this, but this is,
Well, I mean, I feel like I've discussed, I think I need to know what you specifically want.
she said, I heard Amanda saying that she told Amanda that you knew what you're getting into.
Mm.
yeah, we talked about
Mm.
it.
We
Right.
talked about it, so don't blame me for causing you pain. I told you.
Mm-mm.
it's going
Blaming
to
the
be
patient there.
blaming the patient. Never, ever
Mm.
blame the patient. Even if they deserve a blame, in some cases they do.
Mm.
Like if somebody, put a 1,500-pound swing set 2 weeks after the surgery for their grandchildren because they feel so good, and then they break all the screw. After you tell them 5 times what the limitations are.
Mhm.
Mm.
So,
Yeah, you
but that's
can't
not
say I
about
told
that.
you.
No, you
Yeah, you cannot say
never,
that.
no, never ever tell them I told you so.
Mhm. Yeah, who does that help? It doesn't help anybody.
Yeah, it doesn't make you feel better either.
Yeah, but just you still have to document that
Mhm.
that it happened after patient did this and that and so on, because that is you have to document everything. But even if you document, do not assign guilt
Mhm.
or failure or fault at any level. Okay, so they give you, because you want to know what they did, because it's a huge difference if the screw broke when they did that or if screw just broke. One is this is just the normal behavior of the screw. But if they withhold it from you, you have to find out what is wrong with the screw. You have to go and find out what else is going on. So you want them freely share that information with you. So, and if you assign guilt, you will never get the full picture. So you never say, I told you so. You never say, but we talked about that and so on, except extraordinary circumstances. Those extraordinary circumstances, again, come to different conversation that we are going to have, not to this conversation, because this is about establishing trust and maintaining trust with the patient. So she did exactly the opposite. So I told you how it's going to be. Don't be like a little child playing, acting up, and so on and so forth. And then another thing is that she gave you the feeling she doesn't want to spend time with you. She want you to get you out of there.
Yeah, I felt like I should leave right away. She basically was like, you can stay in here and recover. I would have preferred if she said something like, you can stay here as long as you need, or, you know, something along those lines, but it's more like, you can stay here for a couple minutes. Do you know how to leave? Do you know how to get out type of stuff?
Yeah. And, you know, you have to give them you have to give the patient the feeling that, you know, that again, they're in charge and you're there for them when they need you. And all of that didn't happen. Now, having said that, my father used to say, even the worst person is good as a bad example. So we can even learn from a bad surgeon or bad doctor with bad bedside manner what not to do. So, and these are all good learning points. Now, you came back to something as well. The psychology of patient care is not done without psychology of staff and family, both ways.
Yep.
Dominic, what do you think what I mean by that psychology of staff and patient's family? What do I mean by that?
Yeah. So it's not just this isolated relationship we have with patients.
Correct.
They see so many other people, and then they also sometimes bring other people here, or even if they don't bring their family in, they go home to them.
Yeah.
Yeah.
And so a lot of the times, if you satisfy a patient, but let's say you don't satisfy spouse as well, they have concerns that get ignored during the visit, then that is just going to be even worse overall.
Okay. So let me give you some practical examples. Okay. A few months ago, I have a patient in our surgery center, and that patient woke up with lots of pain. Okay. Now, some of our staff, mostly less experienced staff, they were emotionally totally involved in that situation. And patients, they smell it. They're like if I go there and my face goes white, patients smell that. Okay, and this is a counter reaction. There is a counter reaction to the patient. This must be really serious if the person who's taking care of me is almost panicking. That has something to do with experience, even in the most difficult situation. And that situation wasn't difficult at all, by the way. Okay, it was just a less experienced patient, experienced staff that didn't expect that some patient will wake up in pain. Okay, and then that escalated. When that escalates, sometimes you have to intervene very early. Number one, you remove the person on the staff side that is escalating rather than de-escalating patient's emotional response to the pain, because pain is an emotional response. And we are talking about pain here because that is something you are going to deal with very fast, very soon. Okay. Now, I go on around and give a talk about the nature of pain. And in that, one of my picture is somebody with a broken leg sticking out. We have no problem understand that is painful.
Right.
And then I saw another picture with a broken leg, but it's inside. You don't see it. It's a little swollen. Then you're emotionally a little less involved. But then I saw a patient, an elderly with a bad back that has the bone is grinding the bone. They're in effect the same. But then 90% of those patients are told it's in their head. Okay. But then I show another picture, somebody's hanging in my presentation. It's actually online. You can look for it. It's called on YouTube, the nature of pain. Somebody hanging on hooks that are 4-inch long, and they're hanging on their skin on that. And the guy is there and he's smiling and enjoying it almost.
People
So,
do that for like carnivals and stuff.
well, you see, the pain is a signal. Our emotional response to the pain is what makes pain going one way or another. Okay. Now, you can change that emotional context of the pain in any situation, one way or another. Changing in the bad way is your staff that taking care of the patient escalate it up and start, making that face, your face, like Misha would be a really bad nurse there. His face expression would drive everybody to panic.
Yeah.
Whereas, in this situation, is that first of all, you have to explain to the staff why this pain is normal. I put 6 screws in the patient's back, each of them size of my index finger. You cannot expect Robert, fictitious name, not to feel that. It is normal to have pain. This is what I tell them. I'm surprised for all the other patients who woke up and didn't have pain. Okay.
I'd agree.
So, and most of the time you do a little work and you have to intervene early. Number one, you remove that nurse from the care or that staff from the care, educate them a little before they go back. You make them understand it's normal, and at the end of the day, we are expecting them to behave professionally. And then in that case, we just gave 20 of ketamine, and then he was fine. 1.5 hours later, he left the surgery center and so on. So, and obviously you have to know your craft, how to deal with the situation, because some patient will have that kind of thing. You need to know your craft. Your confidence has to come from knowledge, not from dumb, like a gorilla knowledge. That you have to know your craft and you have to manage the problem as well. But you have to do it in a calm way. You cannot panic. As a provider, you cannot panic, because once you panic, especially people are looking up to you. Once you panic, everybody else is going to jump off the windows. Okay. So
I'd agree. If I saw you panicking or when I see you on edge, I instantly get a little
Yeah.
have you seen me panicking?
I don't know if I want to go straight panicking, but I can tell when you're more on edge.
I'm attention.
Yeah,
I get quiet.
Oh, we
And
know.
I pay attention to the patient. Now, I do not, you will not see me
Not in
panic.
the OR.
Yeah.
No, I'm talking
even
just in general. I'm talking like in life.
Yeah.
Oh,
No,
not in the
in
OR.
life.
No, I would agree that you're very stoic.
In life, he doesn't panic. One time we were driving and the tire was on fire. He's like, "Oh, okay, calmly pull over."
You see, actually, my grandmother went for colorectal surgery a while ago, and I was there with her. And I think the nicest thing that I heard from the surgeon when he came to visit was, "Hey, grandma's name here. I know you're very nervous, but the most important part is I'm not."
Oh,
And
that made her
it's
feel.
That
was a
is
good thing to say.
sometimes I do use that. I go talk to the patient before the surgery and they're so excited and they're so emotional and so on and so forth. And I tell them, I will take care of you. I know you are, anxious and so on, but I'm not. But don't worry, you will be sleeping. I will take care of you. But you don't give them promises. You say, yes, this is a surgery. This I know this has risk. This has and so on and so forth. But I have a good staff here. I have a good team here. I have done this so many times and so on. And I'm not nervous about it. I know you are, but I'm not. And so on. You give them that gives them a confidence that you have to make them feel they are in good hands.
Yeah. That goes all the way back to the trust, because that's not built off lies there. You're telling them,
Yeah.
You're going to do
No,
these things.
you cannot lie to the patient.
Exactly.
Would be, now, sometimes I tell to the patient, this is not a regular surgery. This is a difficult case. But listen, I feel comfortable doing this.
Mhm.
But as well, the other side is, if you don't feel comfortable doing this, you shouldn't be doing this to start with. And you
Yeah.
tell them as well, okay?
Mhm.
There's some situation, I tell them, we could do that, but I think it's better not to do that for this reason, for this reason, for this reason. But let's go back to the very psychology of managing the staff, okay? So you have to involve them, you have to educate them. And sometimes you have to as well lead them, sometimes very firmly,
Mhm.
okay? Because when we take care of the patient, who's our priority?
The patient.
Patient.
Is the staff our priority?
No.
No, not priority. They're important, but they're not priority.
Mhm.
So, and if somebody, and again, people are people, staff, doctors, and so on, you just discuss a very unprofessional doctor. So sometimes you have to be a leader and put them in place. Sometimes you have to remove them from the care.
Mhm.
Now, the situation is very different if that person who escalates the situation is a patient family.
Yeah.
Mhm.
Now, let's talk about the psychology of, you go to the room and you see there is a codependency of the patient and a family member.
Mhm.
They escalate each other. Patient is moaning and is in pain, and then the family then, what is going on? What's going on? And then that sort of, that goes
Mhm.
can clearly escalate and so on.
Mhm.
And sometimes coming back as well, I apologize, I forgot something about the psychology staff, managing the staff, is I tell when I go give these talks is, it is 2 milligram of dilaudid to 4 milligram of dilaudid every hour for patient's pain, not for nurse's comfort.
Mhm.
Okay, do you understand where I'm going?
Yeah, yeah.
Because
It'd be really easy to just keep giving them meds and keep
until
drugging
they
them
don't
up.
complain, until they
Yeah,
don't
no one's
complain.
complaining when they're,
Sedated.
yeah. Right.
Or not breathing sometimes. That goes sometimes that way. It happens every day in the United
Yeah,
States that
correct.
somebody had to get reintubated, or people even die of that. And you have to make them understand, they have to check their emotions, because nobody want to hear a moaning patient in pain. But even worse than that, nobody wants to reintubate the patient in the floor in a suboptimal situation because you gave them too much medication. So that is regarding the staff. You have to make them understand what tools should they use. Like I tell them, look at the patient. Let's make sure they are looking into your eyes. And when I'm telling that, imagine you are the nurse.
Mhm.
I'm looking into your eyes. Say, listen, I understand you want to help the patient. The pain is this, PRN,
Mhm.
but they have to look into your eyes, talk full sentences, and be oriented times 3.
Yeah.
Uh-huh.
Before you give that, well, you do that, you give it 20 minutes to half an hour, and then you go to the next step, you give this medication. Do not wake up the patient to ask them how bad the pain is.
Yeah.
And if they cannot look into your eyes and so you educate them as you go, and they should, you should get annoyed, right? They should have known that already. No, well, wake up to reality.
Mhm.
Every day should be education for everybody.
Mhm.
You learn few things along the way.
Mm.
So, but you have to as well involve the psychology and education in your dealing with the staff for psychology of patient care. No, you cannot do all of that with patient's family.
No.
Mhm.
So,
Yeah, you can set expectations with patient and staff, but sometimes it doesn't work out the same.
well, with the family, it is that you go there and the first thing you want to do is you want to remove them from the room, because you know they have a negative impact on patient care, and they will force your staff to give medication until patients quit breathing,
Mhm.
and so on. What to do? Alyssa, tell me, what should I do?
Yeah, no,
Practical
It's-
steps.
yeah.
Not
I mean, it's-
ideological, philosophical thing. Practical stuff. I go in the room, everybody knows this is a bad dynamic,
Yep.
and so on and so forth. What do I do?
I guess the biggest thing I do is make sure that everybody in the room realizes that we're here for the same thing. I'm here for the patient. They're here for the patient. Okay, patient, what can I do to help you? I understand you listen to them. You have to.
Let's simulate
Okay.
something.
Oh,
Amanda is the patient, I'm the family.
I don't, Dominic,
And
I don't like
Just
the
tag team.
simulation.
okay, listen.
It's like-
Yeah, but okay.
It's okay. It's okay. I'll get beaten over the head. Let's do it.
Mom,
Yeah.
mom,
My doctor.
So, no, then I'm pushing you. I don't like this. She's in pain. She needs something. I cannot see her in pain and so on. Go, you. Go,
Amanda, are
what
you
the,
in pain?
I'm in some pain.
no, not some pain. You are in a lot of pain because you and I, we have been having this dynamic.
I've been
You're
in pain for a while.
not with that voice. Oh, doctor, I can't.
I
can't.
thought,
It's the
I
worst
thought the
pain.
family's the one
Look.
who's like.
No, but
making
it
worse.
goes back and forth. You
Oh,
escalate me, I escalate
Okay,
you.
okay, I
No,
get it, I get
both
it
of
now.
our pain is
Sort of.
10 of, both of our pain is 20 of
Now
10.
his pain.
yeah, yeah.
Mr.
mom is
Armacost, I
picking up
understand.
too.
Well, no, I guess you're right. I am in a lot of pain.
Okay, so then this, my big thing. Tell me, describe your pain. Where is your pain located?
Everywhere. No, we passed
No,
that.
I got, well, I gotta
Okay.
figure out where Amanda's pain is. We gotta establish the fact that Amanda is the one who is in pain and that her perception of her pain is the only person that matters here. And mom needs to understand that at some point as well, that we're all on the same
Mhm.
page of helping Amanda
Sure.
get out of pain.
Sure, I give it to you. Go. Go. No, good. I'm giving it
So
to
is
you.
that what
Go.
you just said to mom, or is that what you're saying to a bossy?
I said that to a boss.
Okay.
I did not just give that speech to mom.
Good.
No, I did not.
Yeah, yeah.
So,
I didn't think
just
you
to
would. I
clarify.
didn't think you would, but
Go ahead. What do you think?
Honestly, yeah, I would probably just be talking.
okay,
Let's go ahead. Let's go ahead. Be mom.
Let's be
Okay.
mom.
Yeah, let's see if how hard I fail at this.
We just got here.
Okay. How are you feeling, Amanda?
I'm in some pain. That's why I'm here.
Okay. All right. Well, we'll go ahead and take care of that for you. I see you brought your mother with you.
Yeah, my mom actually takes care of me on the weekends. She knows how much pain I'm in.
I tried to stop
Okay.
the simulation before it started
Yeah.
because I
Because
knew.
Amanda, I think I'm in something. No, this is already has gone. I'm talking about not managing the pain because
Right.
we established this is I already have done my ABCs and I know this pain is a normal pain. It is not about really treating the pain. This is about the psychological aspect of managing the psychology of the family, the patients.
See, my biggest thing, I guess, that I've noticed when it comes to family,
Mhm.
like, because I do a lot of the conservative management, the pre-surgical type of stuff. So I have had ample amount of situations where I've had, spouses come in. I say, okay, well, I think we should really try physical therapy and give it a shot.
Mhm.
Patient says, okay. Spouse says, no,
Tried
we're
that.
not doing that again.
Yeah.
We've done that before.
I like your accent. Yeah?
And then you go, and then the spouse is like, I did do that 5 years ago. That didn't help me at all. I just want to get
No,
the surgery
Let's
done.
stay with
And
the
then-
let's stay with the hospital room right after
Mhm.
the surgery, and patient and the family are escalating. No, let me tell you what I do. I'm sure there are better way of doing that.
Mhm.
First, I go there and I explain to that. You remember, I have done my homework. I know it is a normal thing. It's just
Hmm.
about the psychology of the thing. You reassure them that it is not. It's really nothing is wrong. You have looked into things
Mhm.
that this what what you see. Unfortunately, you did a big surgery. This is painful. You don't diminish it down. You don't say that it's
Mhm.
not real pain. You say this is real pain, but these things are painful. You have looked into things. You examined the patient. Already have done that. Okay. Again, you have done your homework. Now
I
go.
have a question.
Go.
Was our simulation right after surgery?
Yeah. That
Oh.
one.
We all thought this was me walking into
That
the
explains so much more why happy, cheerful Amanda is just
That's
like.
when I was being
Okay.
normal.
Okay.
No, it's perfect now. It's perfect now.
I'm
We're
sorry.
together now, though.
Okay,
I
sorry.
understand what you're talking about.
Page turned, we're all on it now.
Very
Do you wanna-
stupid.
I was trying to get us to go to. Put me in that, so just flip it. It wasn't explained well.
Yeah, good. Okay, my fault. So,
We're back.
okay, so first you do your homework,
Hmm.
then you reassure the patient and the family, and then you acknowledge that I understand that, you don't want to see her in pain. It's hard to see her in pain. This is hard. And, I'm going to do whatever I can to make it better. And you do.
Mhm,
But then you tell them as well that I know for you, comfort is first, but please allow me to have the safety first.
mhm,
You please allow me to have the safety first. You put them fictitiously in charge because no, this is not a question. Safety is first. We are not in charge. They are not going to prescribe medication to my patient until they quit breathing. But you fictitiously, you put them in charge that they have a saying in that on the safety issue. Please allow me to have the safety as my highest priority. Okay, we are never going to do something that hurt the patient, no matter what. Okay, this is not even a choice.
Right.
Okay, but we still give them some saying in that. Okay, but doctor, she had never been. This is like I've never been in pain like this ever in my life. She says that, and she
That's probably
and
maybe borderline.
and well,
Have you had this surgery before?
yeah, well,
Have you been
and
here?
then the family is going back and forth, angry, looking at you, and so on and so forth. So you demonstratively, you examine the patient, you look at the incision, you do all of that, even though you have done it all before. You go look at the medication with the nurse and so on, and you modify like, oh, let's go to with the Robaxin instead of Q8. You have to become, unfortunately, in that situation, very theatrical about the things you do.
I have a very good example of this.
Mhm.
So you had done surgery up and we're with Crooks near Alamere, and the patient was in a lot of pain. Okay. And I found this out at the post-op call, and they told me, I said, how's pain doing? Oh, it's doing better. So, oh, okay. They said, Dr. Bassi came and saw me. He upped my meds. Oh, okay. I'm so glad that you got that figured out. I don't even acknowledge the medication. I go and I look and what he did. What meds did he up? He didn't up the narcotics. He just changed the
And I didn't even lie to them.
hydroxyzine.
I didn't even
No, you
lie
up
to
it,
them. And
right,
he did up the medication.
Right.
You just don't
Exactly.
have to
But
But
you have
to
to do-
them, you made a change. To
I
them.
took their complaints seriously.
Mhm.
I reassured them, and I did something about it. What I did about it, I did the safe thing about it. But you have to do it in a very theatrical. I go with the nurse in a very stern thing and so on. Okay, what is that? Make it Q instead of Q8 to Q6. And what is that? And sometimes, I order Toradol, which is a pain medication. It's just not narcotic. What's important, I order the Toradol IV. Why? Why do I? If a patient, if I notice a psychology of the pain, emotional response to the pain, especially between the family and the patient, I go and order a Toradol IV. Why not PO?
They don't have to take it. They don't take it.
No,
Well, they
no.
don't.
Everything IV has much higher placebo effect than they have the same effect, but IV has 35% more placebo effect than when they see somebody with a syringe come in and inject that. And I go sometimes outside, I make sure patient is awake, the family is looking,
And watches them administer it.
they don't do that thing quiet. Do it, put a little theatric to that, and you would be surprised. The placebo effect is actually a measurable effect. We would be, as provider, dumb not to use that in our repertoire. And so you go and instead of, you give the 15 milligram of Toradol, but you make sure everybody knows you're giving 15 milligram of Toradol IV.
And it makes sense because as you were saying earlier, pain being linked emotionally. If you see something happening to you that is supposed to be managing your pain, you're going to have a better response to it. The whole idea
Even
there.
let's
If you believe it.
Yeah.
Yeah.
no, they have done those studies. You can go for all practical purpose, give a 2 cc of normal saline
Mhm.
and still reduces their pain 35%. So, but no, you give them a real medication, but put a show on,
Mhm.
okay? And then you would be surprised how much difference it makes. And put that show on as well for the family. And then, but you have to be honest as well to the family. You have to tell them, trust us, we take care of her if you are here or not.
Mhm.
Let us take care of her. She needs rest. I think you need rest too. Please go. You go get a rest. We take care of her. We are here for her.
Mhm.
It is a stressful thing to you. I appreciate that.
Mhm.
Then all of a sudden you treat the family like a patient as well. You acknowledge their same rules apply. You acknowledge their concern and so on.
Well.
And then, but you tell them as well, you don't tell them, God, you're driving her crazy. But you tell them, go get some rest. We are here for her. Okay. But whatever you do, get them out of the room.
Mhm.
Okay. Okay. Now, I think we are on time now.
Yeah.
Any other question? Anything else? I hope you had some from this. Yeah, some practical tip, not philosophical, ideological thing and so, but some practical step.
Yeah.
What you can use in your next patient encounter from
Yeah.
this. Yeah, good. Any question? No?
No, I guess the only thing is, just kind of want to iron something out because I feel like this has been a common thread for it, is that in a lot of these, when you're explaining things to the patient, and if the family has to stay around for whatever reason, or even staff are around, if everybody has sort of the same expectations of what's going to have, the patient's not going to be disappointed because they're going to be informed.
Mhm.
The family members are going to feel that way too, and even the staff isn't going to, because
Right.
they know what they're going to see at the end. So.
Mhm.
Yeah, communication.
Well,
Thanks for watching. This was Essence of Medicine. We talked about the psychology of patient care. I'm Amanda Armagast.
I'm Melissa Haber.
Dominic Moore.
and I'm Dr. Bossi and said, thank you for joining
Have a
us.
safe weekend. See you next week.